to talk about implementation science and epidemiology and what we can do to think about lifting of strategies and challenges specific to de-implementation as opposed to implementation. My personal background, I'm an infectious diseases specialist. I also did an infection control fellowship. And for a little while, I was the hospital epidemiologist out in Denver, where I was the hospital epidemiologist during the Ebola scare. I'm not going to call it an outbreak, but there certainly was concern that Ebola was going to begin spreading in this country. I then came back to VA Boston, where I focused primarily on epidemiology and implementation research, as well as reducing the 17-year lag between the generation of evidence and its translation into practice. So I am going to be talking very broadly about some concepts in implementation and de-implementation, using some models from outside of COVID, but I think some of the lessons we know from implementation science are directly applicable to where we are now. Just some disclosures, I was the site PI of a study funded by Gilead Pharmaceuticals. In particular, I was the site PI of the Pine Tree study, which was the outpatient remdesivir study. I am a consultant for DLA Piper, which is a law firm, Crico and Medtronic, on topics related to surgical site infections. And my research is funded by the VA Health Services Research and Development Service, NIH, NHLBI, and the American Heart Association. So a roadmap for what I'm going to talk about today. First, I'm going to do sort of a broad overview of what implementation and de-implementation are, in addition to what we mean when we say implementation strategies. I'm then going to get into a case study of perioperative antimicrobials and the National Surgical Care Improvement Program, which included some antimicrobial use metrics for preventing infection and reducing postoperative adverse events. I'm then going to go into some of the successes and limitations of that program, as well as the limited stewardship and infection control that occurs in non-surgical invasive care, and how we can think about needing to expand and adapt what we know from the surgical setting into procedural settings. I'm then going to talk a little bit about implementation and de-implementation theory, drivers of current practice, models of learning and unlearning, and perhaps some of the theoretical basis for why de-implementation can be more challenging than implementation, talking about ways we can map de-implementation and implementation barriers to implementation strategies to try to achieve change, and then I will be happy to answer some questions. So first, just to get everybody on the same page, because I know we have a wide audience with many different backgrounds. Implementation is defined as the active process of promoting and adopting an evidence-based practice. It's sort of the what of implementation science. De-implementation is defined as reduction or removal of harmful or wasteful or unnecessary practices. So sort of if implementation is the active process of promoting an evidence-based practice, de-implementation is the active process of reducing ineffective practices. Implementation strategies are interventions that are used to promote a practice change. They're the how of implementation science. So early in implementation science, these were called implementation interventions, but due to some confusion and difficulty distinguishing implementation interventions from the intervention that you were trying to implement, the field sort of moved towards describing these implementation interventions as implementation strategies. And so when we say implementation strategies, what we mean are various things that we are doing to try to promote the implementation. So the Surgical Care Improvement Project, just sort of a broad overview. The Surgical Care Improvement Project was a large nationwide project designed to improve perioperative outcomes. And the Surgical Care Improvement Project had many different elements, some of which included measures to try to improve antimicrobial use around surgery. So what they did was they took evidence-based and guideline recommended practices and translated those into specific metrics, which were then nationally reported. And these included antibiotics given within 1 hour prior to skin incision, and discontinuation of antibiotics within 24 hours after skin incision. Up to 48 hours were allowed for cardiac surgery. And so these evidence-based practices, antibiotics within 1 hour prior to incision and early discontinuation of antibiotics, were translated into 3 different metrics. SCIP-INF-1, which was prophylactic antibiotic received within 1 hour prior to surgery. SCIP-INF-2, which was appropriate choice of antibiotic. You want to make sure your antibiotic matches the bacteria that are likely to cause the infection. And SCIP-INF-3, which is discontinuation of an antibiotic within 24 hours of skin closure, as I mentioned, up to 48 hours of surgery. And at the time SCIP was implemented, compliance with these measures was around the 60% threshold. So why did SCIP include these antimicrobial use measures? Well, we know that antibiotics given before surgery prevent surgical site infections, and surgical site infections are among the most common and most costly of all of the healthcare associated infections. But antibiotics continue to unnecessarily cause harm. And so on the one hand, we want to make sure we are balancing the benefits of the intervention, giving the antibiotic before the surgery, with the harm of the intervention, which is that antibiotics given for a longer period do cause long-term harm. And so this issue of long-term harms is demonstrated on this slide here. This is the daily risk of acute kidney injuries among surgical patients who do not have infections at baseline, and daily incidence of C. diff infections also among surgical patients who do not have infections at baseline. And as you can see, that among patients who got antibiotics, so these were prophylactic antibiotics, not for treating an infection. These were just antibiotics given to prevent surgical site infections. The incidence of AKI was 11.7 when antibiotics were continued for 24 to 48 hours, 17.34% for antibiotics given 48 to 72 hours, and almost 30% when they were given for over 72 hours. Similarly, rates of C. diff increased from 0.5% to 1.1% to about 2%. So put another way, the number needed to harm for acute kidney injury for giving antibiotics for an extra 1 or 2 days was about 9 patients. For giving them for 2 to 3 days, it was about 6 patients. And for over 72 hours, it was between 3 and 4 patients. You'll get 1 additional acute kidney injury for those additional antibiotic days. For C. difficile infections, for antibiotics given for an extra 2 days, the number needed to harm is about 2,000 patients. For 2 to 3 days, about 90 patients, and for over 72 hours, about 50 patients. And so what we know from this is, again, antibiotics, we know giving antibiotics before surgery is very helpful for patients. Antibiotics given after surgery don't help patients, and in fact, they cause preventable harm. So what can we do to begin to address this problem? So the SCIP program was actually extremely successful. So the program was highly successful for improving process measures for surgeries included under its umbrella. And so among the relatively limited number of surgeries that were covered by SCIP, we achieved greater than 97% compliance for the measures that we were looking at. We found improvement in process measures, including a reduction in postoperative antimicrobial use. And we found that the improvement in the process measures was associated with a decrease in postoperative adverse events, including surgical site infections. So when we reduced antibiotic use, we actually also reduced surgical site infections. And so this program was implemented in approximately 2010. And in the setting of very high levels of compliance, it was sunsetted in 2015. So by 2015, we had achieved high and consistent rates of compliance. And so we discontinued the antimicrobial use metrics under the SCIP program. And although the program was highly successful among the procedures that it targeted, it was quite limited in scope. It only targeted major inpatient surgeries, and no outpatient or procedural specialties were included, including cardiac devices. So what did not work as well? So these are some examples from outpatient surgical specialties and procedures that were not covered by the SCIP program. SCIP targeted things like major CABGs and major cardiac surgeries and orthopedic total joint replacements. So things like arthroscopies and more minor surgeries were not included. In addition, entire specialties like ENT and GU were actually not targeted by the program. And so this is a distribution of antimicrobial use and prophylactic antimicrobial use following cardiac device placement. As you will see, the median duration of post-procedural antimicrobial prophylaxis is 5 days, even though we've known for a very long time that giving antibiotics after a procedure does not reduce infections. And this is an analysis looking at post-procedure antibiotic use following various specialties to look at how practice varies across specialties. We include eye surgeries as sort of a negative control because antibiotics do not penetrate the eye well. And so antibiotics given systemically following an eye surgery, we assume are sort of what should be the baseline rate or the baseline expected rate of antimicrobial use. And so you can see following eye surgeries, we have like about 0.5% will receive antibiotics during the week following surgery. For general surgeries, we see that some general surgeries were targeted under SCIP. We see very similar rates to eye surgeries. So for general surgeries, the SCIP program does seem to have achieved its goal of not only impacting those inpatient surgeries that were targeted by the program, but also diffusing throughout the specialty and leading to better practices throughout the specialty. In orthopedics, they also do pretty well. As I mentioned, total joint replacement procedures were targeted by the program. Arthroscopies were not. And we see pretty good uptake of the program, but not perfect in orthopedics. And then as we go to specialties that were not included by the program, like ENT and GU, we see we still have pretty high rates of post-procedural antimicrobial use, even though we've known for decades it's not effective. So in summary, although the SCIP program was successful where it was targeted, we see substantial lack of diffusion or lack of spread of the innovation to other surgical and procedural specialties. And so one thing you could argue is the procedural specialties are different. Maybe giving antibiotics in these settings makes a difference. And so this is a graph demonstrating all VA facilities that perform greater than 50 cardiac device procedures per year. And this is looking at variation in antimicrobial use and infection use. So these bars are procedural volume. This line represents the proportion with postoperative antibiotic use lasting for greater than 24 hours. And this is the proportion of cases with infection, with cardiac device infection. And as you can see, I think demonstrated quite clearly on this graph, there's absolutely no correlation between antimicrobial use and infection rate. In fact, if anything, there's a trend toward a higher rate of infections among the facilities that are giving more antibiotics. So we know there's a problem. We know we're using too much antibiotics, and we don't necessarily know why. And so we don't know what we can do to change this practice. And there are some theories about challenges that are distinct to de-implementation as opposed to implementation. We know that factors that influence the implementation success include several internal and external factors, including guideline support for the change. So if I have a clinical guideline or a guideline from a national guideline issuing body like the CDC, guideline support for the change helps achieve de-implementation. So it's much easier to promote or achieve a change if the guideline is supporting you than if it is not supporting you. The strength of the underlying evidence. So the strength of the underlying evidence supporting the guideline recommendation, either for or against, also helps to determine whether or not the implementation is successful. The better the quality of the underlying evidence, the more likely you are to achieve success in either promoting the intervention or de-implementing the intervention, depending on which way you want to go. The complexity of the intervention. So implementation interventions are often pretty complex. A lot of the fields came out from behavioral psychology, and a lot of psychology interventions are complex and require multi-levels and multi-people. So the more complex the thing that I'm trying to do or not do, the harder it is to achieve a change. Patient and provider fear and anxiety about changing an established practice. So even if we have evidence mounting and guideline changes, when there is anxiety or fear about moving from one practice to another, that is a major barrier to de-implementation. There tends to be a bias towards a focus on near-term as opposed to longer-term outcomes, and on outcomes that are easy to measure as opposed to outcomes that are more distant and harder to measure. And there is a lot of concern about long-term risks of delay or decisions to forego testing or treatment. And one of the places where we've seen this sort of most starkly is when we look at decisions about cancer screening and, for example, prostate screening and prostate cancer treatment. Now that there's sort of a recommendation for a watch and wait option for many patients who have prostate cancer, patient concerns about the long-term risks of delay and decisions about foregoing treatment have sort of demonstrated this challenge. There's also a substantial healthcare worker and public health bias based on personal experience and personal experiences and anecdotes. There's also a general bias in healthcare and in public health toward intervening as opposed to not intervening. And so this general bias is we want to do more, so it's harder to do less. And the final sort of major determinant and major challenge in de-implementation can be a lack of trust in institutions and in guideline issuing bodies and public health and the healthcare system in general. So we know there's a problem, and we know there are lots of factors that contribute to these problems. So what can we do, and how can we begin to think through this problem and how to address it? So first is to identify drivers of current practice and then map the barriers to de-implementation of the ineffective intervention. And then a second piece is to address informational gaps and informational feed gaps. One of the most a very important implementation strategy is audit and feedback and providing information. But providing information is not without its own challenges. And then develop a system or for testing a bundled implementation or de-implementation strategy. So I keep on talking about these implementation strategies just by way of background. There are approximately 73 evidence-informed implementation strategies. The number does increase relatively frequently, but there's sort of 73 established ones. And these 73 evidence-informed strategies fall into 9 major categories. And these include things like consumer engagement, informational strategies, which are things like evaluative or iterative feedback or providing feedback on more than one outcome. Adaptation to a specific context. So context is really important in implementation science, and oftentimes things that we find work in one place do not work in another. And so thinking about the context and the specifics of what's going on is critically important. Stakeholder engagement. So getting buy-in from the people who are actually going to be participating in education and training. These evidence-informed implementation strategies can be then mapped to known barriers to implementation or de-implementation, as well as facilitators to implementation and de-implementation. So I'm talking a lot about the barriers. There are also things that make implementation or de-implementation easier, and you should leverage those to your advantage. We also know that bundles of strategies, multifaceted strategies, and strategies that are tailored to the specific context of the specific challenge are generally more effective than single strategies or strategies that have not been developed specific to the context. And we know there are many more studies that have looked at effective implementation strategies than effective de-implementation strategies. We have a relative dearth of research into de-implementation. So why is de-implementation so hard? So if you think about it, when you're going from the implementation phase, what you're trying to do is get somebody who wasn't doing something to do something. The thought about de-implementation, and part of the reason why de-implementation is harder than implementation, is that de-implementation is a 2-stage process, whereas implementation is a 1-stage process. So this gets into learning and unlearning theory. So Helfrich et al. Describes unlearning as a process in which clinicians consciously change their knowledge, beliefs, and intentions about an ineffective practice and then alter their behavior accordingly. And so if you think about it, if we want to achieve the implementation, we have to unlearn one thing and then learn to do something else. Whereas when we're talking about implementation, we're just trying to talk about learning to do one thing. And we know that unlearning can occur either alone, so we can just say, don't do this anymore, or unlearning can happen in combination with substitution, which is replacing an old practice, generally one that is ineffective or out of date, with a new practice. And most in the field of implementation science feel that when we're trying to achieve the implementation or unlearning, unlearning models that include substitution or replacement tend to be more effective and more long-lasting than the implementation strategies that attempt to achieve unlearning on its own. So 2 examples. So this is an unlearning coupled with audit and feedback, and this does not include substitution. So in this case, we're exposing providers to new information, and we're giving them feedback, and we're giving them feedback about their use of antipsychotics and the dangers of using the antipsychotics. The idea is that once we give the providers this information, that causes a critical reassessment of new evidence against the ineffective practice. And then that reassessment of the effectiveness of the intervention leads to intention to change, and that leads to reduced use of the ineffective practice. So basically, all I'm trying to do is I'm saying, you know what, this doesn't work very well. That causes you to realize it doesn't work very well. That leads to a decision to change and ultimately change. Alternatively, unlearning with substitution works where what we do is once somebody sees that there's a problem, instead of saying, hey, this doesn't work anymore, we're going to say, do this instead. And so it's the idea that we can substitute that practice with something else. So when somebody needs antipsychotics or they're concerned about agitation, instead of giving that antipsychotic, we're going to recommend a DICE protocol and do what we can to support this alternate protocol. And rather than simply asking people not to do anything, we're asking them to do something else. And that this then leads to uptake of the alternate intervention and ultimately reduced use of the ineffective practice. So back to the antibiotics. Now that we've sort of talked a little bit about what implementation strategies are and what learning and unlearning are, how can we put this all together and think about mapping barriers and facilitators, adapting to specific contexts, and linking all of this to implementation strategies? So my particular interest is in reducing unnecessary antibiotic use. And so in pursuit of that goal, we engaged frontline providers, key stakeholders in the process from across the country, and we gathered data about their current practices. And we took specific context and, again, stakeholder input into, and then we mapped them. We also saw input from the key stakeholders on what drives their current practice. We asked them why they did it and what drove them to decide to give antibiotics, even in light of evidence that they don't work. We then qualitatively coded these interviews and mapped responses from the interviews to evidence-informed implementation strategies to develop a comprehensive de-implementation bundle. And so what did we find? When we spoke to providers, there was universally a desire to optimize outcomes. And so I think it's important to remember that when providers are doing something, even if it is something that is not effective, it is typically to help their patients. And so when we spoke to providers, what we heard was cardiac device infections are highly morbid, patients die from them. I really want to do everything I can to prevent bad things from happening to my patients. And so, so that was an important facilitator. Providers really do have a desire to optimize outcomes. Other facilitators were support from local content experts or opinion leaders. So if we heard from the infection control department that it's okay to change this practice, they're more likely to do that than if they hear it from somebody who they don't regard as an expert. The strength of the underlying data. So if there's strong data to suggest that I don't need to do this, I'm more willing to do this than if there's less strong data. What barriers do we find? So one was a lack of resources. So what we heard a lot was my patient comes in, I put in this pacemaker, and then they go and I never see them again and I don't know what happens to them. So I want to do everything I can to prevent an infection from happening, because if I don't see them again and I don't do everything I can now, I'm not going to be able to take care of them later. There's lots of feedback about difficulty monitoring patients and concerns that problems wouldn't be identified. So if I change my practice and I stop antibiotics, how are you going to know something bad didn't happen? Other barriers, lack of knowledge about consequences. So when we spoke to providers, we asked them, so has anything bad ever happened to your patient from giving prolonged antibiotics? And many of the providers said, I've never had a single patient in my career ever get C. diff from antibiotics, right? So, and that gets to what information is fed back to providers and what they hear about. But that sort of falls under the umbrella of a lack of knowledge about the consequences of an intervention. And then there was also a concern about providing non-standard care. Like if I stop giving these antibiotics and my patient gets an infection, I'm going to get sued because everybody else gives antibiotics. So those were kind of the major facilitators and barriers. And then to design our multifaceted implementation intervention and our model of care, we took these barriers and facilitators and mapped them to implementation strategies. And so this includes informational feedback about not only cardiac device infections, but also non-cardiac outcomes. So getting to the issue of we want to optimize all outcomes, not just cardiac device infections. And so if we're going to optimize the overall care of the patient, we need to look at the whole care of the patient. Engaging local champions to receive and provide audit and feedback and provide education. We also developed an automated and centralized surveillance system to measure infections, antimicrobial use, and adverse outcomes. And we're going to be providing this information to providers. So not only are we going to be providing them information about the that may be infecting their patient, we're also going to be monitoring if any problem does occur, we will be able to identify it. And so how are we sort of applying these concepts in practice? Well, so we have this theoretical model, and it sort of looks like this. So we have a patient who undergoes a cardiac device implantation. And let's say they have a cardiac adverse event. So by that, I mean their pacemaker could get infected, it could have a hematoma, the device could fail, the lead could come out. The electrophysiologist immediately receives feedback about that adverse event, right? So if somebody has an infection and the pacemaker needs to be removed, you're going to call the electrophysiologist. And so the electrophysiologist sees that adverse event, they see how bad it was, and they immediately try to take action to reduce that adverse event in the future. So what happens? More antibiotic prescriptions. And you end up in this feedback loop. The other side of this loop, though, is that there are also adverse events related to guidelines of important antibiotic use. And so we talked about acute kidney injury, C. difficile, allergies, there are others as well. But if somebody has acute kidney injury, you're not going to call somebody who puts in a pacemaker, you're going to call a kidney doctor. If somebody gets C. diff, you're going to call a generalist, an IG doctor, or a gastroenterologist. Again, you're not going to call an electrophysiologist. So, after reflecting, it wasn't surprising when we conducted these interviews that the electrophysiologist And so this issue of unseen events and how providers receive and interpret information, we believe is a critical aspect for thinking about de-implementation. So, and we are testing our multifaceted intervention in a 3-center quasi-experimental study. We do not yet have any results but we are going live with the information feedback and the multifaceted implementation strategy that we are testing, and we are hoping in the next couple of years to be able to answer whether or not impacting some of these information feedback loops and providing more balanced information both about risks and benefits and looking at specific and more general outcomes can change practice. So in summary, implementation is hard, and I would suggest to you that de-implementation is even harder. Barriers to de-implementation are not always the same as barriers to implementation, and we need to adjust our strategies accordingly. Unearned learning models can provide clues for how to achieve successful de-implementation, and we may need to think about two-stage processes and removal and replacement as opposed to simple removal. And linkage of known barriers to evidence-informed implementation strategies and strategy bundles may facilitate de-implementation. At this point, with a joke about hospital staff, I'm happy to take any questions.
All right, Westyn, thank you very much for that a study of how treatments should happen and don't happen. I know the early days of the pandemic were fraught with treatments that proved later to be bad, and ranging from ventilation that shouldn't have happened to more simple, clever things like being put on your stomach instead of on your back. And it took a long time for new procedures to become standard. Yeah.
So I think there's an average. So the pandemic, I think the pandemic is a very specific example, but on average, it takes 17 years from the time an intervention is demonstrated to be effective until it's stably implemented into practice. So we've seen things really rapidly implemented, but that means we're also going to think about how we can, all of these things that we've implemented and stood up over the past 2 years, or lack of effectiveness, and as vaccines really change the landscape of what is needed and what is not needed.
And so I guess by that standard of time, things were lightning fast in the pandemic in terms of change. Yeah. Well, I think a statement of the status is that well, I'm not seeing any other. Oh, Eric, you have a question?
Yeah. Thank you, Westyn. I think I have a simple question. Maybe you answered it and I just missed it. When you talk about the challenges to de-implementation, and I realize this is going to be sort of a problem-specific answer, probably. Are you able to evaluate those quantitatively? So put a scoring rank on each of the different parameters that you listed,
I think
for
that
example?
we're hoping to do in the VA, we can leverage guideline-based changes and look at different factors. What we're hoping to do is take the NIH guidelines, classify them according to the date when the guideline changed, and then look at how long it took for something to be implemented versus how long it took for them to be de-implemented, and then look at various factors, including strength of the evidence, type of facility, academic affiliation, and looking at whether or not which factors sort of weighed the most strongly in terms of implementation and de-implementation, and then relative lags between implementation and de-implementation. Like, I think, it gets to be pretty complicated. You see, just looking across the VA, you see, for example, dexamethasone use rises within a week of the, New England Journal of Medicine article being released. I suspect that other interventions took much longer to be implemented, right? So I think, and that's because when dexamethasone was released, it was the only intervention that we had, right? Dexamethasone was really the only medication we had when we found out it was effective, that we knew was really effective. And I suspect as as we've gotten more and more options, right, I think probably dexamethasone was implemented the fastest, followed by remdesivir, and then tocilizumab and some of the other immune modulators that are more controversial and work in a more selective population and have more marginal effects, I suspect took longer. So I think it's going to be a combination of how many options you have, what the strength of the evidence is, how strong the effect is, what patient populations are targeted and how complex it is to identify who needs to be evaluated. And so we are hoping to look at some of those factors and begin to quantitate some of them. But I think it's going to be a fairly complex matrix involving all of those different things.
And
hopefully that answered the question.
yeah, it does. I was thinking of something more simple, and that was sort of doctor-patient survey questionnaires and asking, which of these factors impact your decision. Is there something like that involved?
For COVID, I don't know. For the antibiotics, I think when we did the interviews, it was very difficult to get to that level, right? So, because it's very, very hard to get people to sort of put their finger down on one thing. My suspicion based on the responses that fear of litigation was a major driver. And that was to overcome this idea that if I don't provide standard of care, I can get sued. Even if what they're actually doing is providing not the standard of care. So it's sort of a strange cognitive process. But in talking to them, that was the thing that I got the most strongly. And I will also say there are things people are willing to say to you when you're sort of officially doing research and officially doing interviews. And then there are things people are willing to say to you when the microphone comes off. And when the microphone comes off, a lot of what you get is, it's really because I'm afraid of being sued.
Okay, thank you.
Thanks. Well, just a closing comment. I get it totally that it's probably easier to get people to change, to change from what they're doing to something new than it is to get them to stop doing what they're doing and do nothing, because everybody wants to do something. So the idea of doing nothing, even though that might be the best thing, is really hard for people to accept.
Yes, and I think, a good example of that, I think, was hydroxychloroquine early on in the pandemic. When we had no evidence-based treatments and we had this, scary new pathogen coming towards us, most of the guidelines across the country recommended use of hydroxychloroquine. And I'm talking about the institutional guidelines. And I think a lot of that was this can't hurt, could help, and kind of a bias towards doing something. And it being very difficult from the point of view of a clinician to look a patient in the eye and say, we really don't have any options.
Right.